All right, so we have just started, Palmetto GBA has just started recording this open meeting in compliance with CMS. For the record, prior to doing so, I did announce that Palmetto GBA would make an audio recording of the open meeting, and I did consent on behalf of Palmetto GBA. All right, so we're just going to work our way along with this agenda. We are right on time at this point. The first presentation is regarding, I believe, the intercept procedure. And this involves Mary Haley, Dr. Ray Baker, and Dr. Michael Marks. So I will let you all proceed.
And Grosu, so I'd like to begin by thanking you for the opportunity to present today on the thermal destruction of the nerve base vertebral nerve for vertebrogenic low back pain. On the call is myself, Dr. Ray Baker, Mary Haley, our Vice President of Relievant of Health Economics and Reimbursement, and Dr. Michael Marks, the Senior Medical Director in the Health Economics and Reimbursement Department. Just a little bit of our background. I won't spend a lot of time on this. I'm an anesthesiologist by background, interventional pain management for 25 years. Past president of both the North American Spine Society and the Spine Intervention Society. I was the founding co-chair of the CMS Multi-Society Pain Work Group, and I've previously chaired the United Healthcare Spine Advisory Board nationally. We have Mary Haley, who is the global vice president for a number, vice president of Neuronetics and at Medtronic, and as well as a previous case manager. And Dr. Michael Marks, a senior medical director, past president of Connecticut Orthopedic Society, senior consultant at Karen Zapko Associates, and VP of Business Development at Western Connecticut Health Systems and QM at Oxford Healthcare. So today I'll be quickly going through the clinical evidence, society support, and Dr. Marks will be discussing the 2022 coding information. Really what I'll be presenting is only new information and not information that you already have in hand. So getting on to the clinical evidence, just a high level, the clinical data to date, we believe strongly supports an LCD for this procedure. We have two meta-analyses that are level 1 data, both supportive. We have two level 1 randomized controlled trial. The SMART trial was a sham controlled trial with a positive outcome, and the Intercept trial against standard care that was also a positive outcome. We also have other lower level studies, but overall we have data right now out to 5 years with our SMART trial and out to 3 years with the Intercept randomized control trial. New data that you did not have as a part of your application, we have two meta-analyses and systematic reviews. The first is a meta-analysis that was performed and published in the Open Journal of Radiology. I think the conclusion is what I'll drill in on here is the radiofrequency ablation of the base vertebral nerve in the treatment of chronic low back pain is safe and may be helpful in a carefully selected group of patients with demonstrable modic type changes with improvements in patient outcomes achieving 2 to 3 times the minimally clinically important difference. The second is a single arm meta-analysis and systematic review that was recently published, and I'll get down to the results of that. Really, they're moderate quality evidence using the grade criteria that BVN radiofrequency ablation effectively reduces pain and disability with patients with vertebrogenic low back pain. So two supportive published meta-analyses that are independent. We also had a group of 5 articles published in Pain Medicine Supplement. One of those was a Paper of the Year award at the Spine Intervention Society. But the first article is really an editorial encapsulating or distilling the other articles. But the main articles that I'll drill down just a little bit on is the relationship between the patient demographic and clinical characteristics of successful treatment outcomes for BVN ablation, a pooled cohort analysis. So essentially what we did is turn over all clinical data to an independent group of physicians who worked with a statistician to help to characterize what successful BVNA RF ablation candidates look like, where their pain is located, what makes them worse, what makes them better. Is there any demographic data that we could do to maximize success of this procedure? So they looked at where the patient demographics were in this, as well as the clinical characteristics. They also looked at pain location. Was the pain midline? Was the pain paravertebral? Did it radiate into the buttocks or legs? Things like that. And they also looked at the aggravating and alleviating factors, as it works with sitting, standing, walking, so that the clinician was able to get an idea of what this patient really looked like. Finally, they did a study on what the MR findings would show in the successful patients, MODIC 1 versus MODIC 2, the amount of MODIC, other things that would allow you to note and have confidence that you were selecting a potentially successful candidate for BVN ablation. These findings came out with, as you would expect, the pain is usually midline in the majority of cases. It radiates at times into the buttocks, but not into the lower extremities. MODIC type 1 and MODIC type 2 are equally well treated with BVN ablation. And the amount of MODIC is not predictive of the outcome, meaning a small amount of MODIC changes on the vertebral body was equally as successful as the patient had a large amount of changes. Moving on to updated society policy statements and treatment guidelines that have been published since the application, I'll point you to an updated International Society for the Advancement of Spine Surgery guidelines that were recently published, showing concluding that collectively the studies reviewed demonstrate BVN ablation demonstrates clinically meaningful improvements in pain and functions at 5+ years with an excellent safety profile. This evidence supports BVN ablation as a treatment option for well-defined subpopulation of chronic low back pain patients. And very recently published was the American Society of Pain and Neuroscience guidelines. They, based on a USPSTF criteria with modification for interventional pain studies, the ASPEN work group gave BVN ablation a level A grade for high certainty that the net benefit is substantial in appropriately selected individuals. So if you look at the collective evidence going into this hearing, this meeting, we have 15 clinical study publications, 1 systematic review supportive, 2 meta-analyses supportive, 5 literature reviews, 3 independent studies, both in and outside of the US, showing kind of independently the effect of BVN ablation and the results of regression analyses data. We have the ISAS policy that was recently published, as well as the ASPEN treatment guideline. And as a final reminder to the group, NASS, the North American Spine Society, led this code, which is very unusual. It's also more unusual that we went straight from an unlisted code to a Category 1 CPT code with the help of societies that included PM&R, pain management, anesthesiology, and spine surgery, with North American Spine Society and ISAS all joining in. So it was really a multi-specialty support for this procedure. Dr. Marks, you want to go through the coding information and then we'll conclude.
Okay. Good morning, and again, thank you for allowing us to present here today. We certainly appreciate the positive LCD. As we recall, the diagnosis that was listed for it was M54.51, which was actually a new code that was added in October of 2021 by the CDC to the ICD-10 code set. However, we also would like to request the addition of those other codes that are listed here: M47.816, 817, M51.36, M51.37, and then the non-specific low back pain, as all of them are codes that would appropriately describe an individual who is appropriate for basivertebral nerve ablation, with the M54.51 certainly having the greatest specificity. And again, we thank you for allowing us to present and are certainly happy to answer any questions that you may have.
All right. Are there any questions from the contractor medical directors on the line? If I hear nothing, I shall assume that we're good.
All right, I appreciate again the opportunity to speak today. Thank you.
Yes, thank you, Dr. Baker and Dr. Marks. Thank you for that additional evidence-based literature and some of the society guidance. We appreciate that. So we remain on time. We're going to move ahead now. And I would remind everyone again to please keep your cameras turned off if you're not presenting. We'll move on to the transurethral water jet ablation of the prostate. This is going to involve Barry Templin, Dr. Kreitman, and Dr. Singh. I'll let you proceed.
All right, thank you. Good morning. I will share the slides in one moment. Okay, good morning, everyone. Thanks for the opportunity to present. My name is Barry Templin. I'm a Senior Vice President at Procept Biorobotics. With me today, I have Dr. Louis Kreitman from Georgia Urology and Dr. Inderjit Singh from Potomac Urology. Here you can see our conflicts of interest noted here. Briefly, what aquablation therapy is, it's a robotic procedure for men with suffering from LUTS due to BPH. It's a heat-free water jet resection utilizing real-time image guidance and then executed after the surgeon has identified the contour plan of the obstructive tissue they want removed. The initial LCD was effective 12/27 of 2020, which we appreciate that. That was based on early data from the Water 2 study, both being FDA studies, as well as the Open Water study. At that point in time, we did have strong society support, as well as obtaining transitional pass-through and NTAP from Medicare. The proposal today is to remove the indication for only covering men in the age less than 80 years of age. You can see
what's happening.
So I think somebody.
What the hell's happening?
I'll proceed. So based on this, we have a growing body of evidence that I, as well as the surgeons joining us today, will present. It will be consistent with our FDA labeling that was approved in December of 2017. And I will just briefly list a number of commercial policies that do not have the age restriction currently as we sit here today. Since the original LCD, there has been a number of publications come out. There are 3 systematic reviews you can see listed here. Essentially, the conclusion is aquablation can achieve TURP-like efficacy, however, maintain that preservation of sexual function like the office-based procedures of Rezum and Urolift. Since then, the Water 5-year data, which was the randomized study against TURP, has been published showing strong, durable data where only 6% of patients had to go back on either meds or be surgically retreated compared to 12% in the TURP arm. And lastly, the Water 2, which was a single-arm study against a performance goal for FDA, has now published 3-year results, and again, showing consistent results as we've seen it 1 and 2 years previously. Just briefly, here's our FDA label. There is no contraindication for prostate size, prostate shape, or age of patient. Here's the current list of commercial payers with positive coverage decisions for aquablation in the market, and none of these carry an 80 years of age cap, which has allowed this population to be treated. And here's where I'm going to turn it over to Dr. Inderjit Singh to talk about some of his personal data, as well as Dr. Kreitman's experience with this population or this subgroup. Dr. Singh, I will turn it over to you.
Hi, good morning, everyone. Thank you for allowing us to present our data. My name is Dr. Inderjit Singh with Potomac Urology in Virginia. I've been in private practice for about 30 years and have extensive experience with aquablation, which I've been performing since 2018. Next slide, please. As you can see, the published data for patients over 80 years, these are 4 studies that have been published outside our experience that showed that the results have been excellent, and the highest age was 88 in one of the studies. Next, please. So here I'm presenting 3 private practices, including myself and Dr. Kreitman, and one from, is it Long?
Chicago.
Chicago. We had 30 patients who were over 80 years old who had aquablation between June 2018 and December 21. The mean age was 82.7 years and average prostate volume was 90.4. As you can see that they are basically similar size as water. As far as the prostate volume is concerned, it is almost same as water 2, which is 90.4. Baseline IPSS, which is the symptom score, is equivalent, and the baseline Qmax is also equivalent. All 30 cases were completed successfully, and no cases were aborted or converted to another surgical resection. And in reviewing and discussing the outcomes with the providers that we have discussed above, the overall outcomes of the symptom score and peak urinary flow rates were comparable to water 1 and water 2 studies. And out of 30 patients, 27 were treated in the outpatient setting, which is really remarkable considering the age of the patients. So it illustrates the fact that this is a procedure that should not be withheld from this patient group who require help, and they are actually more morbid clinically than other younger age group, but aquablation has not been given to them, and they should be really qualified for that. Out of this, only 2 adverse events were noted that did not affect the outcome. One was sepsis, the other was clot evacuation. There were no transfusion, no ICU admission, or death within 30 days. So I really strongly recommend that the aquablation should be offered to patients who are over 80 years old, and I strongly urge Medicare committee to allow that to happen. I'll be happy to answer any questions.
Thank you, Dr. Singh. I will turn it over to Dr. Kreitman, and then we'll open up the floor for questions. Dr. Kreitman?
Yes, good morning. Thank you. And thank you for the committee for allowing me to take some of your time to discuss aquablation and the age group that we're currently looking at. My name is Louis Kreitman. I am a partner and an executive with Georgia Urology in Atlanta. I have 52 partners, and I'm the BPH and voiding dysfunction specialist. So I've had an opportunity to use lots of different types of procedures to treat patients of all ages and treat patients with prostates of all different sizes and shapes with variable lower urinary tract symptoms. Like Dr. Singh, I've had an opportunity to treat about 300 patients' prostates with this modality. Next slide. Our primary goals for surgery in this age group really is to do a procedure that's going to improve their quality of life, that's going to improve their symptoms, and do it in as quick a procedure as possible. Obviously, in patients who are 80 years and older, we get concerned about how long they're spend on the operating room table. There is no procedure that we can do in patients who have large glands as quickly as we can do an aquablation. And I think when we compare the types of procedures that we do, especially for very large glands, you're going to find that this procedure is going to be one of the safest ones, mainly because of the limited amount of time that we have in the operating room with these patients. In my opinion, there are lots of different procedures that we can use, including laser procedures, including simple prostatectomies, especially for the large glands, including transurethral resection of the prostate. All of those procedures are going to take longer, therefore going to be a little bit more morbid because of the time that we spend on doing that procedure. And when you have a patient who has a very, very large gland, your choices are either to do an open prostatectomy, a simple prostatectomy, or the aquablation. Aquablation is going to be a safer procedure for those patients. Longer-term efficacy responses in this age group treated with aquablation at Georgia Urology has been very good. It's been the same as our patients that are under 80 years of age, and we've really not seen any differences because of their age in doing this procedure. Next slide. And so commensurate with other BPH procedures, we request the committee modify the indications to remove the age limit on these patients, because it really doesn't make a lot of sense for us out in the community and in academic centers that we be limited to not be able to use this modality in patients that are older. We'd certainly have consistency with the FDA indications where there is no restrictions. The new clinical evidence that Dr. Singh presented confirming clinical outcomes consistent with the published FDA data, and the real world experience that those of us who treat lots of BPH patients really does confirm that the surgical risks with aquablations are similar or less than the BPH surgical techniques. And I'll echo again the importance of getting a patient off the table as quickly as possible. We can't do it any other way. There's no other modality we can use, especially in the very large glands, especially in a patient who's in retention, where we can get patients off the table and have such great outcomes. Thank you, and I'll take any questions.
Thank you, gentlemen. Again, I'll offer the opportunity, a pause here to see if there are any questions. I want to thank Dr. Kreitman and Dr. Singh and Mr. Templin. Appreciate your presentation very much. All right.
Thank you.
So we will move along. And again, I'll just keep putting this plug in. Make sure to turn off your cameras if you're not going to be presenting. So our next presentation now is dealing with the near-infrared spectroscopy in wound and flap management. And I believe our first presenter in this regard is Erin Buckness with Mercy Wound Care and Hyperbarics.
Okay, good morning. So my name is Erin Buckness. I'm a clinical nurse manager from Springfield, Missouri, and we've been using the snapshot since about March of 21. The snapshot application in the Wound Care Center, we use it not only for assessment of all lower extremity patients with an ulcer, compromised flaps and grafts, HBO patients. We also use it for monitoring initial ongoing trend improvement, negative changes or stall wounds. It has helped us expedite vascular surgery referrals, arterial Dopplers, and potential surgical interventions. It's also improved our collaborative care across our hospital with multiple medical offices, physicians, and also has improved our limb salvage program. Here is a great story snapshot. The image tells a story. 59-year-old male active smoker with PVD, non-healing VLU to right medial and lateral lower leg. An arterial Doppler done showing 75% stenosis of the right superficial femoral artery with monophasic flow from the right popliteal to right perineal arteries. Venous Doppler also showed significant venous reflux involving deep and superficial veins. The first image here you can see is pre-vascularization. The second image is your second image is 3 months post-vascularization and venous ablation. Now, the red, which is high oxygenation, and the blue, which on that first image you'll see is more medial and posterior. We want red. The red shows high perfusion. In this gentleman's case is revascularization and showing improved flow. In general, the blue is bad, decreased local perfusion. It also can show decreased cardiac output, anemia, or potentially hypoxemia, ischemia. This second image, so this is a patient with unremarkable arterial Doppler from an outside facility. We imaged her, and from that, we sent her to our internal vascular surgeon that it completed an angiogram with findings of high-grade stenosis of pedal arch and posterior tibial. Angioplasty was successfully completed, and the patient went on to heal shortly. I can honestly say without snapshot for both of these patients, they would not have the ability to heal, or we would not have had the ability to adjust our plan of care as quickly as we did. Diagnostic assessments that are others that are used. So ankle brachial index is kind of the gold standard within the industry for peripheral arterial disease and assessment and diagnosis. But what you don't know is that the 29% of critical limb ischemia patients have normal or near normal ABI values, and 40% is amputation rate for patients with PAD diagnosed within the first year. This is a national average. The challenges of ABI, non-compressible vasculature, collateral circulation will be present even with complete occlusion of main artery supply, perfusion not assessed in the foot, variations in technique, and that's within even the same office. The more advanced the arterial disease, the less reproducible reproducible the results. And toe brachial index, it's not commonly performed. It's 13% of critical limb ischemia patients will have normal TBI readings. Variations of technique, again, even within the same office, and the lack of use, documentation, reproducible results. Now, we've had this technology since March of 21. It's like, well, how are we going to use it? So you can see in that first box, we use it on who we use it on. So all lower extremities, wounds with negative changes, and treatment. So we're a Healogics clinic, and we have goals. So if it's less than 4 weeks, greater than 40 weeks and less than 50% healed, we will re-image. Now you'll see our different pathways. First pathway is normal. We'll just continue to monitor. Our second pathway is 40 to 69% where we see a stalled wound or abnormal reading. So that's where we'll get our additional images, start the patient on 81 milligrams of aspirin if they're not already on a blood thinner, order arterial Doppler, and we will repeat those images Q week. Our third pathway is less than 39%. Again, we'll get those additional images, start them on aspirin. We will refer them to vascular surgery, order the arterial study. And then this was a request from RCV surgeons, was to order an ABI with digital pressures. That way they have all the information they need to make a decision on whether this patient needs to proceed to a vascular intervention or to angiogram. The last box is, are we implemented with our hyperbaric oxygenation patients? So they get weekly image. That's our Wagner grade patients, our diabetic foot ulcers, and all our compromised flaps and grafts. They'll get it weekly at their wound care appointments. We have used it for monitoring serial debridements as well. The area shows area of a debridement. The red shows microvascular circulation and predicts this patient will heal. It will help us track wound healing, wound progression, improvement, complete debridement, has helped us prep the wound bed for cellular tissue-based products, and has helped us document medical necessity. And you can see that's a big jump from SCO2 of 22% to 86% post-debridement. This patient is a 67-year-old female who is diabetic, presented to the ER with gangrenous right foot. Arterial Doppler diagnosed her with ischemic arterial insufficiency and arterial occlusions involving the right popliteal, perineal, and anterior tibial arteries. Vascular surgery performed a right popliteal cut down, popliteal and tibial embolectomy for acute limb ischemia of the right lower leg. Podiatry was consulted and completed a first amputation. Both vascular surgery and podiatry recommended a BKA. So you can see here in these images to the left, so the SCO2 pre-HBA was 46 to 79%, post it was 57 to 73. Deoxyhemoglobin, which we use a lot for our patients that are receiving hyperbaric treatments, start off at 0.15 to 0.49, which is extremely high. And this is her first treatment, 0.18 to 0.37 was her post. Wound base as well, pre 44% jumped to 71%, and that deoxy from 0.46 to 0.29. We healed this patient, and we showed that we could do it using the snapshot. She did not go on for further surgery or further amputations. So implementation outcomes. Since implementing and effectively using snapshot technology with the developed protocol, we have been successful in decreasing both major and minor amputations. This has been achieved through the early assessment of peripheral arterial disease, the appropriate referral of patients to vascular surgery, and early intervention. In addition to improved clinical outcomes, we're also seeing cost savings for the patient, their insurance companies, and our hospital. This is because we can change our plan of care quickly to be more effective. Our utilization since March of 2021, since implementing March of 2021, snapshot assessments for patients with lower extremities, compromised flaps, non-healing wounds, and HBO assessments. Snapshot INR utilization has improved a mechanism to assess oxygenation, develop and apply more appropriate care plans, has streamlined our referrals to other service lines, including vascular surgery, orthopedic surgery, and podiatry, and has helped my providers identify 17 patients with critical limb ischemia, preventing amputation. hyperbaric oxygenation therapy and cellular tissue-based products, utilization, documentation, medical necessity and outcomes, preventing overutilization, document medical necessity, able to trend improvement, HBO pre and post treatment, and specifically limb preservation. My providers also were awarded 2.76 RVUs. So we went to our internal RVU board and requested them. The information we brought was presented showing our limb preservation results. The compliance program of snapshot utilization for advanced therapies, for HBO, cellular tissue-based products, debridements, physician time, and their expertise. The reimbursement shows the image interpretation. Providers must determine what they see. Providers must correlate the results and images from the snapshot NIR with the current clinical presentation. And information obtained is not visible to the human eye, and one image gives us more information than an ABI ever could. Providers must evaluate underlying conditions, medications, previous interventions, and histories to appropriately interpret images. And the interpretation utilizations. The providers must use the above interpretation to assist in formulating a care plan that is appropriate for the goal of therapy. They also assess the need for additional intervention or diagnostic assessment, and they evaluate the need for further systemic optimization and control of comorbid condition. That is all I have this morning. If anybody has any questions, I'd be more than happy to answer anything.
Thank you so much, Ms. Buches. Appreciate that. We have several presentations on this topic, so we'll move ahead. Next, if you're ready, Dr. Toole with Kent Imaging.
Yes, thank you. Just to introduce myself, my name is Dr. Doug Toole. I'm a podiatrist based in private practice in Salt Lake City, Utah, and we have offices throughout Utah, Idaho, Colorado, New Mexico, and rapidly growing. We're a multidisciplinary practice. Focused largely around advanced wound care, vascular, and neuropathy treatment algorithms. And so it's my pleasure to be here today and share with you the insight that we've developed in my world regarding this snapshot device. It's definitely, I was the first, I believe, to utilize this a couple of years ago. And it's after a slight learning curve, it's really dramatically actually changed our treatments, or I should say guided our treatments and guided the compliance of the patients regarding the things that we're doing. It's helped us in terms of, and I had a case study that was sent to you guys, and you can certainly reference that. It was just one example of many patients where we were able to really guide their treatment and compliance and such. But from a practical standpoint, we were able to really show patients images regarding their oxygenation and even vascular type perfusion, and they're more compliant with even getting vascular studies. Patients that present with wounds, we're able to show them, even as far as, like healthy debridement of tissues. It's certainly guided my debridement. Went back, I would say, multiple times, especially in the early use of this product. I went back and found that I was kind of under debriding relative to what a lot of the images would instruct me to do. And so as I got familiar with that, I was able to actually do better debridement, which again, the naked eye just doesn't really show you that. In terms of using, biologic graft applications, it certainly guides that therapy. If you feel like a patient warrants that, the snapshot can either confirm or guide you away from that therapy. And so certainly has helped to decrease overutilization. I would definitely say that that's the case to a very large extent, actually. We've had patients who are very non-compliant. My practice, especially in the pandemic, saw a lot of home-based patients on home health and really severely bad. And basically a lot of them, they could see if they were not getting better based on the oxygen levels in their wound, even despite whatever therapies we were engaging with them. It could persuade them to get into a surgeon or a vascular intervention, endovascular physician, for example, and to get the help that they needed in that regard. Also able to show them, when treatment algorithms are working, a lot of these patients with these terrible wounds, they have very little hope. And so their compliance is very poor because they have very little hope. And, you know, they've had this wound on their leg or their foot for, 6 or 7 years or something. And it's kind of, just waxed and waned, but largely waned. And as we can show them that our therapy is working, they get very excited, and that just emotional boost that they get from seeing the wound improving on the images and seeing literally the percentage of relative tissue O2 perfusion being higher in the wound, even if they clinically or physically with the naked eye can't see that necessarily week to week because it's a very slow process. They see that and they're very motivated, and so they'll basically do whatever we tell them to do, and their compliance really picks up from that point. Which, I mean, as physicians, we can do what we can do, but we really depend on them being more compliant. These patients don't get these terrible wounds because they're, a picture of health and compliance typically. So that's very much guided our treatment algorithm. So to kind of sum up, I would say that our big advantages in using this therapy is to be able to first physically see if debridement has been successful. It's also physically able to see way more than an ABI can show you in a very specific way. We're also able to guide our advanced treatment algorithms and see if specific advanced treatment therapies that we have approvals for and are using to see if they're necessary and if they're working well, literally week to week. And the also easily mobilized in terms of it can be used, and it's easy to take to a facility or a home or whatever it is, and you can very easily do that. And then it guides compliance in the patient so that they're able to see if something's working. It also guides our referring habits and such, as we make referrals a lot of times based on the improvement, but also based on the images, and patients are much more likely to go. That is the main facts that I would share with you this morning, and I won't take any more time, but I'm happy to answer any questions if anyone has any. Thank you very much.
Thanks, Dr. Toole. Appreciate your comments greatly. We'll move ahead to, this is also Kent Imaging with Maura Sistis, Liz Newell, and Dr. Jeff Niezgoda. So I will let you all take over.
On behalf of Kent Imaging, I would like to thank the entire Palmetto team for allowing us this opportunity this morning. I am Jeff Niezgoda, the Chief Medical Officer. I wanted to present our agenda. We are going to be discussing several issues raised by the proposed LCD for NEERS of a non-coverage policy. We really want to discuss the current literature. The rationale for determination in the proposed Palmetto non-coverage LCD suggested, quote unquote, a lack of level 1 evidence and lack of clinical practice guideline endorsement. And we will show that the literature review that was accomplished as part of your determination was not comprehensive at all, and that the current literature does support clinical adoption and endorsement. And this is going to be evidenced by not only our presentation, but several testimonies, which you've already heard from Aaron Butchness and Dr. O'Toole. We are also going to be talking a little bit about clinical interpretation, which you've already heard, and how it enhances clinical decisions. And then we're going to leave you with some cost efficacies and a request for reconsideration of the non-coverage policy. We're all here today because of this unfortunate truth. Diabetic foot ulcers often result in complications and amputations. And Aaron Butchness talked about how they used NEERS to prevent amputations in 17 patients. Regarding research and publications, the rationale for determination included a review of only 11 papers. And this review omitted nearly all the publications between 2020 and 2022. Kent has provided you with an extensive bibliography with a total of 19 publications that were published between 2020 and 2022. Additionally, another 8 studies that were not included in your review between 2018 and 2020. And in fact, we provided 35 total references, only 2 of which were reviewed in the Palmetto determination. Now, COVID obviously had a dramatic effect on the ability to conduct any type of RCT, but despite COVID, 27 of the 35 studies that were published during COVID. I would now like to ask Liz, our Vice President of Clinical Affairs, to comment on 3 select studies.
Thank you, Dr. Niezgoda. The studies cited in your LCD were focused on postoperative flap monitoring when looking in the plastic surgery area. They didn't touch on intraoperative flap assessment. This first study is a prospective cohort study of 51 surgical sites, and they found that Snapshot NAR can actually be used intraoperatively to predict flap necrosis. The second study, if you want to jump to the next slide, perfect. This is actually an RCT. It examined 81 chronic wounds and demonstrated that healing wounds compared to non-healing wounds had significantly different STO2 trends patterns. And you'll hear Dr. Niezgoda talk about the trends and how that impacts clinical decision-making shortly. The third study also looked at trends, and this one had 34 patients undergoing angioplasties. This study demonstrated that a successful angioplasty also resulted in a clear increase in STO2 in both the wound beds and the peri-wound areas. I will hand it back to Dr. Niezgoda now.
Great, thank you, Liz. Here are some additional studies that were not included in your review. And, you know, the determination rationale actually commented on the Chen review and the Kagaga study. These two studies looked at hundreds of patients. In fact, 710 free flap procedures, and additional 430 that were done without NIRS. That was the control group. And these studies showed significant differences, p-values of significance with salvage rate and flap failures. This was in the group that where NIRS was incorporated versus the control group. Now, it's interesting to me that the proposed LCD policy analysis really just simply dismissed this data. And I think these are statistically significant results in very large trials. And they did so because they stated that in the author's papers, they made the comment that further studies are needed to take full advantage of the potential of NIRS. Now, I'm sure I'm speaking to the choir here with the other medical directors on the call who have also published. I've published over 50 clinical papers. And in every single one of these research papers, we always state additional research is warranted. And nearly, you know, every author does the same thing. The truth is we should never stop researching and investigating even after a study is published. But this fact should not allow the impressive results that we just presented in these large data sets to simply be dismissed and disregarded. We also have significant additional publications in wound and vascular, and these, again, emphasize the clinical utilization and benefits of NIRS. Regarding the determination that basically said that NIRS was determined not to be a supplement for the gold standard of clinical assessment, we want to make the statement that we would never suggest that NIRS could supplant clinical decision-making, but rather, as you actually suggested in the determination, we think that NIRS complements and enhances, and this has been stated by Dr. O'Toole and Dr. Butchess as well. And we're going to illustrate this in the next few slides, but we think that is an enhancement. This is published in the literature as well as demonstrated by clinicians. Here is a case from my clinical practice looking at hyperbaric oxygen therapy, which is already referenced. We use near-infrared snapshot to determine response to hyperbaric when outcomes have been reached and when there's non-response. And I think it has a significant impact on decreasing overutilization. Here's some color images. Again, they speak for themselves, as Aaron said earlier. The image on the left obviously is one of extreme duskiness, and the two panels to the center and to the right show changes in the tissue after a single hyperbaric treatment. You can see the reds and oranges on the right after hyperbaric, showing that this tissue has been oxygenated, well perfused, and in fact, this resulted in a salvage. And we use these trends and these images to guide our clinical decision making. We also have heard about cellular and tissue-based products. We see that there has been significant use of the technology in this area. And we really think that the trends that are utilized here suggest that you can gauge response. Here you see again the changes in the deep red and yellow color or orange coloration, suggesting that the wound bed is responding to the cellular and tissue-based product, and you can stop at that point, again, impacting positively on overutilization. We really significantly look at trends, thresholds, and deltas to guide our clinical decision-making, and the determination actually stated interpretation of healing patterns was suggested to be purely are completely hypothetical. I think the prior cases that I just showed you, as well as what we heard from prior clinicians, really suggests that interpretation is not hypothetical at all. Clinicians use the data generated by the image to make clinical decisions and guide their treatments. This is, again, well stated in the publications that we provided to you that were not reviewed in your determination. We have significant evidence to suggest that there are cost efficiencies. Aaron talked about the Mercy protocol, amputation prevention in 17 patients. Simple calculations suggest a 1.5 million estimated cost avoidance to the Medicare program. And this is exactly, how near-infrared technology is used. We use the interpretation of the images to modify clinical treatments in an effort to improve patient outcomes. And, we show different evidence, and we suggested cost avoidance in CTPs. There's another group out there that has reported decreased overall healing rates with reduced visits, again, providing cost salvage. And we have suggested that, flap failures can be prevented and prevent additional trip to the OR, again, cost avoidance. Here's some images showing other comparable and predicate technology. You're probably familiar with some of these, and this is essentially saying that Snapshot is not a pulse ox device, although it's categorized by FDA of that category. All these devices are categorized like that, but it's certainly not just a pulse ox. It's an imaging device. We have received CPT codes from the AMA, and it was also suggested in the determination that there is a lack of clinical practice guideline endorsement, and this is also simply not true. The CPT codes listed here were granted by the AMA, and that was based on strong support from vascular, plastic surgery, and wound care society. And this support continues to grow and strengthen. We're seeing huge alliance between the technology and multiple specialties out there. We talk a little bit about predicate and similar technologies, and this slide shows some of those. It was interesting to me that the rationale for determination actually reported that previous strategies in wound care monitoring, such as transcutaneous oximetry, which were considered so promising, had not predicted benefit. But yet TCOM, as you see, is well reimbursed here. The determination also reported that you found it profoundly striking that despite decades of enthusiasm for NIRS and even other spectral monitoring, there has been little improvement in the quality of the studies over time. We again suggest that this is not accurate. We have demonstrated the robust research that has been published that was not included in the review. It supports the use of NIRS. There is a comment in the determination that TCOM and NIRS from Serena was reported that oxygen levels measured by TCOM and NIRS show strong correlation. So respectively, we again state that the literature demonstrates well that NIRS is a better technology, providing more robust information that can be used to enhance clinical decision-making and improve patient outcomes. And we think it results in cost savings. So Kent is incredibly devoted and dedicated to supporting patients, and we do that in a number of areas: education, research, and we believe that enhancing clinical decision-making is where we need to focus. Again, we talked about the support from our societies, and we attend those symposiums and present and help to educate clinicians. In summary, we believe that this technology enhances clinical decision-making. It optimizes outcomes, facilitates patient selection, and achieves cost efficiency for a number of reasons, but certainly decreasing overutilization in some technologies contributes to that. Limb salvage also contributes. So in closing, we would strongly urge Palmetto to reconsider their LCD policy determination of non-coverage based on the literature, the support, and the clinical support that we have provided today. Thank you very much.
Thank you, Dr. Nisgoda, and thank you for presenting some of that additional evidence-based literature for review. I can assure you it will be reviewed. And just a general plug to anyone even earlier that has remained on this call, we do certainly want your formal comments in writing following this open meeting. Those are intensely looked at and will require us to comment et cetera. So we will definitely want your formal written comment.
Thank you, Lisa. I appreciate that and appreciate the opportunity once again.
Sure, thank you. Okay, so let's move on. I believe next we have Dr. Martin Johnson with Kent Imaging.
And good morning, and thank you for the opportunity to share some thoughts with you. I'm a plastic surgeon. I work at a wound and hyperbaric center in Pomona, California. Previously, I was at the Mayo Clinic in Arizona. My experience as a plastic surgeon, I know some of this has been alluded to earlier, but for the first slide, we just want to demonstrate how this technology is able to assist us in the operating room. So this is a demonstration of a patient who's undergone a nipple-sparing mastectomy. The idea here is to retain as much tissue as possible to allow the patient to have an aesthetic result for an otherwise potentially debilitating procedure. So with the use of this NIRS technology, we talk about the red, green, blue, and if you see in the upper right-hand side, there is a flap that is in the green and blue. This is suggestive that we do not have adequate oxygenation. So using this data in the operating room, we were able to remove that portion of the flap. We ended up with a very satisfactory result. And I think that this is a demonstration of how the technology is able to assist us. Had we closed that with the flap as such, we would probably have had to return to the operating room, and the deep flap, the autologous tissue flap there, would have been deepithelialized to accommodate that. So now you had an additional surgery, and the potential revision on that would have been not only time consuming, but it would have been an additional burden for the patient. Again, as a plastic surgeon, we find this technology particularly helpful for any flap procedure, whether it's a reconstructive procedure or, as we'll show in the next slide, a patient that was referred to us who had a bilateral breast reduction. And as a plastic surgeon, we tend to lose sleep or get gray hair when we have tissue presenting, or the patient presenting with tissue that is very dusky, that potentially is a signal that we're going to have tissue loss. The loss of the nipple-areolar complex is quite devastating and requires multiple reconstructions. This patient was referred to us for possible hyperbaric oxygen therapy. And when we were able to do, again, you can see with the red, green, blue, we'll get a very nice red picture in the nipple and the surrounding tissue. And the oxygenation saturation is very acceptable. So we referred the patient back to her plastic surgeon and told them that we did not think that hyperbaric oxygen therapy was necessary. And indeed, the patient went on to heal without difficulty. These are, I found other indications for it too, treating patients with flap failure after amputations, et cetera. Do they need hyperbaric oxygen therapy? You can also measure their progress during the treatment. I think all in all, it's a very, very useful tool. It's been mentioned previously, we use it for guiding us for debridement. I just think it's a tool that really enhances not only our practice, but once we're able to employ it, I think we can save our patients time and anguish, and I think we're saving people money for this too. So that's basically my offering for this. If you have any questions, I'd be happy to answer them.
All right. Thank you so much, Dr. Johnson, for your insight and personal experience.
Okay. Well, thank you for the opportunity.
All right. So we are just a few minutes ahead of schedule, but I suspect we have our next presenter on board. So Dr. Glenn Jones, on behalf of Kent Imaging, are you on?
Yes, I am.
Okay, great. We'll let you proceed.
Thank you. Well, I'm Glenn Jones. I was a professor of plastic surgery at the Emory Clinic for 15 years, and then have been a professor at the University of Illinois College of Medicine in Peoria for 15 years, and have been intimately involved in breast reconstruction as well as free tissue transfer and limb salvage and so forth during that career. And I was the first person in the world to get the SPY camera from, at that time, Novadak, now Stryker, and used it for nearly 13 years in my practice to guide tissue debridement and assessment of viability. And it was a very helpful device. But as has been well recorded in the literature on many occasions, the SPY device using Indocyan and green technology tends to overread necrosis by about 25%, which means that in many cases where we would have expected tissues to survive, the SPY suggests it's non-viable and we have to debride it, which can make for complex reconstructions and aborting procedures, sometimes in favor of more complex procedures. And it was also an immensely expensive technology. The machine cost somewhere between $250,000 to $300,000. The disposables were very expensive, and there were hidden maintenance contracts, which were also expensive. And so when I was alerted to the advent of the near-infrared spectrum, I was intrigued and started using the device in my practice in tandem with the SPY device, and found that it was very, very accurate, much easier to use. It was a handheld device. The results were very predictable, as I'll share with you in a moment. And the cost was dramatically reduced. The device is only about $30,000, and there are no disposables. The nurses can use this device. It can be transported to the ICU or to the floor or used in the office, as well as in the operating room. And Dr. Johnson has already talked about how you can guide clinical decision-making with this device, just as you could potentially with the SPY device. The question for me was, how accurate was this? Could it be a reliable replacement? What we did was to repeat a study that had been done initially in rats when the technology was first developed in tandem with the SPY in Canada many, many years ago. And we did a rat study, which Dr. Niezgoda has already listed in the publication list, where we compared the SPY with Kent in a rat model with a dorsal skin flap. And we found that the prediction of viability was as good, if not better, with the Kent device. And that was statistically significant. I then moved into a clinical study where we took 58 patients having breast reconstructions. And as Dr. Johnson has alluded to earlier on, one of the biggest issues we have as plastic surgeons is assessing skin viability when the breast surgeon behind most, if not all, of the breast skin, sometimes including the nipple. And we are then called upon to reconstruct the breast either in one or two or even more stages sometimes, often using things like tissue expanders, direct to implant reconstruction, or free tissue transfer like the deep flap that he showed. And if all of these procedures rely on having an adequately perfused skin envelope surrounding or encasing your reconstruction. And implant devices, which are the most commonly used devices for breast reconstruction in this country today, around about 85% of reconstructions are expander implant or implant-based alone. They are very intolerant of ischemic tissue as an overlying envelope. So if overlying an expander or an implant, you now have exposure of the device, which either requires debridement and reclosure, which means a tighter skin envelope with more compromise to your reconstruction and to the aesthetics of the reconstruction, or frank loss of the reconstruction, where you have to simply explant the device, close the patient, bring them back for a later autologous reconstruction, etc. So we wanted, at the time when we started the study, the average skin necrosis rate in most practices that are reported worldwide runs at about 15%. So if you can imagine some of those resulting in skin necrosis with exposure of devices, for you as providers reimbursing these procedures, the costs can skyrocket. And one of the things that I was converting my practice from expander implant with 2 mandatory stages to a single stage direct implant reconstruction, which I've shown in the paper I'm going to allude to, saved us several $1,000s over the long haul in a standard single breast reconstruction, because you were only paying for one device, one visit to the operating room. But you can only do direct implant reconstruction if you're absolutely certain that your skin envelope is fully viable. And that's where the Kent device was immensely helpful. So what I did was to take 58 direct implant patients, and I first performed a SPY image on them, and then immediately after performed a Kent image during and after the procedure to see what that skin envelope looked like and was it giving us accurate predictability. Sharing the slide with you, but basically we had 58 patients. The SPY, typical with its 25% over prediction, suggested that 16 of the 58 patients could run into problems with altered skin viability. And of those 16 patients, only one developed necrosis. So you can see that there was about an 85% error in over-reporting skin necrosis in that patient population. Using the NSIR data, however, from Kent, we found that only one patient was predicted to having full-blown necrosis and one had a suggestion of partial necrosis. And indeed, that one patient went on to necrose as the SPY device showed. But we'd taken away all the anxiety and potential altered clinic by using the Kent as opposed to the SPY device in that series. So there was a very significant difference between the accuracy of reporting between the two devices. And what that did was gave me tremendous reassurance to be able to go ahead with single stage reconstruction, which not only saves long-term healthcare dollars, which is the critical issue for you folks at Palmetto looking into reimbursements, but also it kept my patients a lot happier because women were having a single stage reconstruction instead of the mandatory two-stage with an expander insertion, coming back week after week after week, getting expansion, and then having that mandatory second stage expander implant exchange. And I've often asked surgeons at this, would you as a woman prefer a single stage direct implant or an expander with a second stage? And I never get any takers for the second option. So it enabled me to make my patients a lot happier. We had excellent clinical outcomes, which we reported, and we're in the process of getting that paper published. So in summary, my assessment of the Kent device, and I've used this also, by the way, in lower limb salvage, looking at soft tissue envelopes, amputations, looking at the viability of the tissues to place over the amputation stump. You can look at periosteal blood supply on bone. Dr. Niezgoda and others have already addressed the issues of lower extremity viability in the foot and how it helps with debridement. It's been an to use in clinical practice for decision making, and something that is much more cost effective and I believe far more accurate than the currently widely used SPY device. So in summary, I think this is something that could really impact reimbursement significantly. As Dr. Johnson showed, it can guide us to not proceed with certain procedures that might otherwise have been done in the absence of such data. And that in turn trickles down to greater patient satisfaction, better patient outcomes, and indeed less cost to healthcare providers such as yourselves. Thank you very much.
Thank you, Dr. Jones. Again, greatly appreciate your experience and input. Thank you very much. We will proceed. We have Dr. Craig Walker, also on behalf of Kent Imaging.
Lisa, this is Niezgoda again. I apologize. I got a message from Dr. Walker that he's in a case right now and is not going to be able to attend. He asked me to fill in for him and supply this video presentation, a short video presentation that speaks to his testimony. So can you see my screen now?
Yes.
Okay, I'm going to go ahead and play this, Lisa. Thank you. If you can't hear the sound, please let me know.
Okay, thank you.
Hi, it is my pleasure to follow Dr. Niezgoda to speak about the clinical utility of Kent Imaging System. I'm Craig Walker from the Cardiovascular Institute of the South.
So we can hear, that's all we're supposed to do, right, Dr. Niezgoda?
There's an ischemic component to a foot ulcer.
I don't know why.
Preoperative evaluation prior to Charcot foot surgery. As prior to revascular.
Lisa, I don't know why the video is not playing. Let me, as long as you can hear it, that's most important thing. Let's just go with the verbiage. Like I said, it's short.
Okay.
Component to a foot ulcer. As preoperative evaluation prior to Charcot foot surgery. As prior to revascularization, to serve as a baseline to determine whether or not conservative measures may heal the wound or ulcer, and as post-vascularization to assess adequacy of perfusion and to evaluate for re-occlusion. Now, these are some examples of cases where I found this to be very helpful. This 64-year-old male with coronary artery disease and an ischemic cardiomyopathy. He's diabetic, long-standing. He's a smoker and he's hypertensive. He's had his right leg previously amputated. He's had multiple bypass surgeries with a film pop bypass and 2 distal bypass surgeries on this left leg. And with that, he had developed a large non-healing foot ulcer